louder. How are you?
I'm good, thank you. Are you doing okay? Are you in the office? Or are you in?
I'm at the office, yeah, because it's 2 o'clock here still, so yeah,
For
still
sure.
working.
Yeah, I've been doing a bit of reading in observation today, and I'm quite excited. So this should be a good one.
Yes, I agree. There's a lot to talk to, a lot to talk about.
For sure. For the guys on my account who don't know who you are, could you introduce yourself a little bit and just say what you're all about, how you got into kind of technology, etc.
Okay. Hi, I'm Dr. Salas-Whalen. I'm an endocrinologist and obesity specialist located in New York City, but I'm originally from Mexico, and so I've been in New York almost 20 years, so I consider myself a New Yorker, but always wanted to do endocrinology, especially because of diabetes and obesity.
Yeah.
So, yeah.
And those are two kind of topics that are very important to dentists, whether or not we want to admit it or realize it. With gum disease, diabetes is a big problem, as is obesity. So I think we've got a lot to talk about. So guys who are watching, please first of all share this to your friends who are also dentists or endocrinologists, any periodontists out there that you know, that would be really useful. And also get your questions in, because we're going to learn a lot from the doc today. Could you just give us a little introduction about diabetes? Obviously, we're all medically trained, so we do know a fair bit, but just from your point of view, how you kind of approach things.
So diabetes is basically how I explain to my patients is that you're not utilizing the fuel that is glucose as we normally we should, right? So the glucose, you need insulin to the glucose to go to the organs to where it's needed as fuel. So there's a problem, either not enough insulin or hyperinsulinemia or insulin desensitizing. So they're not sensitive to insulin. So that's basically the diabetes. They're not using sugar as fuel as we normally should be doing.
And in the States, you guys have a big problem with diabetes, don't you?
It's huge here in the United States. They say like 1 in 3 people are diabetic, and even 1 in 2 are pre-diabetic. So it is a huge problem. I think it goes first diabetes and second obesity, but they're almost at the same level.
Yeah. And we kind of find within dentistry, possibly we see things a little bit earlier than maybe you might see the patients, because they'll probably come to you at a later stage. So what are the things that you'd be expecting to see in a diabetic patient who is maybe pre-diabetic? What are the things to look out for?
So I think, unfortunately, diabetes is one of those type diseases that are very silent, that they don't give you symptoms initially until the sugar has been high for a while. That is causing some sort of complication. But it's commonly to see in practice, especially type 2 diabetics that are newly diagnosed. Not that they just had it, but that it's just been diagnosed. We see it's common to see like severe weight loss, like they have a good amount of weight loss that the patient is almost proud if they say, oh, but I lost 20 pounds or 10 kilos, but it's actually from the bad diabetes, right? So we can see unwanted weight loss or weight loss that happen just naturally. Also, another thing, very common, patients that they're waking up at night to urinate, right? So they have nocturia, they're drinking too much water or soda or juice. They just have a very high thirst and hyperphagia. So they eat a lot, but they're losing weight a lot. So that's not something normal, right? And it's very common to see that.
Yeah. Hi, Cami, and hi to you as well. And in the mouth, we can see maybe an increased level of inflammation and pocketing around teeth, which might be an early indicator as well. So that's something that could help to screen for these patients.
Yeah, definitely. I mean, oral disease periodontitis it happens very early in the diabetes, and I read that it can be seen even before we see them in the office, right? So it's something that you guys can catch up and say, hey, have you checked your sugar? Have you seen your primary care? Just to question that, because we may not have seen them yet, and you get to see them first, right?
Yeah, because we would hope people are coming in at least once a year, maybe twice a year, for regular checking and cleanings. What are the tests that we would send for if we suspected a patient, has come in, this unexplained inflammation and bleeding around the teeth, and you're thinking this could be some early periodontal disease, and is it maybe associated with diabetes? The patient's a little bit overweight, maybe. What tests would you be asking for to confirm an early diagnosis of diabetes?
I think here in the United States, our gold standard is an A1C, basically, right? So an A1C, it's going to be more helpful than just a same day sugar that could be affected for any other things. And the patient was stressed, patient had high carbs for dinner, they may give you a one-time high sugar. That we don't take into account. It will be an A1C. So if you guys would do any test, I would recommend an A1C, right?
Yeah, HbA1c. And thank you, Dr. Arti. Yeah, I kind of agree that this is a topic that isn't maybe touched on enough within dental circles.
Surprisingly.
Yeah. And I think that this is a really good way to holistically approach a patient and hopefully catch things before they get too bad.
I was reading, there's a lot of articles, and one of them that was mentioning that periodontal disease and diabetes, it's like a two-way street. So periodontal disease can give you hyperglycemia, and hyperglycemia can give you the periodontal disease. So they feed into each other, right?
Yeah, I think that's one of the things I was, again, I think we've both been doing a bit of reading on each other's topics. The periodontal disease is actually kind of the sixth complication of diabetes. Is that something you're kind of familiar with?
Yes, I was reading that periodontal disease, like severe periodontal disease, can predict almost like worsening A1C on a patient. It can also predict even cardiorenal mortality on diabetic patients. So it plays a really, really important part for the patient to work as a team, you and as the endocrinologist, right?
Yeah, I think for sure. And I was also reading there's a certain study that said inflammation markers were reduced after treatment. And
yes,
that helped with diabetes as well.
Yes, and because of the inflammation of the diabetes, that's one of the reasons that we believe that there's periodontal disease, plus also that diabetics are prone to infection. Yeah. So it's just like the perfect scenario for periodontal disease to happen, right?
Yeah, because as we know, periodontal disease is a bacterial infection, in anaerobic circumstances, and a diabetic patient is more susceptible to these infections. So as you would think, it's going to be a worse result, including the upregulation of certain inflammatory cytokines and kind of that lowered host immunity.
I think it's really important that, especially at least for me in my practice, I will definitely implement more than asking the patient, have you seen your dentist? Have you done your yearly dentist appointment? Because unfortunately here we share patients when the patient is either going to have a procedure and their A1C is too high for the procedure to happen from the dental part. And then we see them just to kind of prep them, fix them, and then we send them back. But that's pretty much like the limit connection that we have so far between dental care and us. It's just like when they're either already really bad and they're going to have treatment, and then we help them, prep them for the treatment, and then that's it. But I think we should be more proactive.
Yeah, maybe you should look at employing a hygiene therapist or something. that might not be a bad shout. Could you tell us a little bit about the management that you enact with diabetic patients? And do you see obviously there's type 1 and type 2 diabetes. Is there much of a difference that we're going to see between the two?
No, regarding periodontal disease and gum disease, type 1 and type 2, I think we'll see the same risk on those type of patients. So I think it's independent of the diabetes. One thing that can make possibly type 2 diabetes worse than type 1 is the obesity factor, if there's any, right? So if there is obesity, then we're adding more inflammation to the mix. So then that may put the patient more immunocompromised for infection and inflammation.
Yeah, Dr. Arti, this will be going up on IGTV, so do check back later and give it a share if you enjoyed what we end up talking about. Yeah, and in terms of pharmacological and non-pharmacological uh, methods of treating diabetes now, where should we be looking at asking patients, are you taking XYZ drugs? Are you changing certain things within your societal habits and things like that?
So I think for treatment, we have different types of medication, especially well, type 1, they will just require insulin. For type 2, then we have a little bit more of a variety of options for patients. And our diabetes medications have come very far, that it controls appetite, it controls weight. So we were missing that link before, that was just treating the diabetes, but we were not doing nothing about the obesity or the weight gain. But now medications actually act on both things, which is great for patients. And I think also changing the eating lifestyles or the eating habits can also help to promote gum health, right?
Yeah, I think that's for sure. Are you somebody who's a proponent of kind of holistic medicine? You know, when we're looking at changes in gut flora, if people are having lots and lots of Coke, for example, you know, they've got the I forget what the actual additive they put in the Coke is, but there was something that changed the gut flora, and then it made you a bit fatter just by having drank that Coke, even though it might
So
be a bit.
regarding treatment, and I would say this goes in anything besides diabetes, I don't mind the holistic implementation as
Yeah,
long as we do the medical
both.
implementation.
Yeah, it's got to be a bit
So
of
it
both.
could be an additive, but I wouldn't depend on it, on the or the treatment of the patient. I wouldn't depend on it. But I am 100% pro healthy living
Yeah.
or free of toxins, free of plastics, free of chemicals, no processed food, no ultra processed food. I mean, I think the cleaner we eat, the better for our health overall. So those things I do support, right?
Yeah, I just wondered because it seems to be a commonality that there is a increased kind of correlation between socioeconomic status.
I was just going to answer. We use all the GLP-1
Yeah.
analogs that help with glucose and appetite control. Initially, they were developed for diabetes, but then we were seeing weight loss, and now we can use it even on non-diabetics for weight loss. But that's the best medication right now for diabetes are the GLP-1.
Yeah. Good question. Thank you for that, Duff. Yeah, I was just saying more about the. I've actually forgotten what I was saying. Someone can remind me
Sorry, I
what.
interrupted you.
No, it's fine. It happens sometimes.
Treatment, no? You were talking about treatment of diabetes and diet and healthy eating, healthy
Yeah,
living.
it was more kind of. Oh yeah, that was it. It was socioeconomic status, the diet that these kind of groups are eating, and then the vitamin mineral deficits as well. Is that a big effect?
Definitely, it is. I mean, we jump into another subject here, which is very important, right? Which
Mm.
is accessibility of good food to the lower socioeconomic. And we have all those implications, which is obesity is one of them, right? So if we can mix them, we are seeing more childhood obesity now. So we're seeing 10-year-olds with type 2 diabetes. I mean, 10-year-olds with type. So then we're going to add all the dental health problems, plus all the complications at a younger age, right? And that can come from the lack of access, the lack of knowledge that there's healthier food, that people can make healthier choices. But unfortunately, sometimes it's not the more accessible economically, right? I mean,
Yeah.
so it's something that it's a whole system change, like school lunches, the cafeterias in school, what they provide, mac and cheese, pizza, sodas. I mean, it's like, it's a whole thing that we need to change. And the food industry is very involved in that, right?
Yeah, and probably quite resistant to the change as well.
Oh,
Probably doing things
yeah,
very
they'll shut you
cheaply.
down.
Yeah.
There's so much money in the food industry that it's very hard to go against them, right?
I know this is again miles off topic, but I was reading a while back that there was studies in the 50s and 60s that were linking cardiovascular disease to sugar, and then the sugar industry paid the is it the CDC? Is that who you have, or is it what's the food thing in the United
The
States?
dietary, it's like
FDA.
the type the FDA, but it's
Yeah.
a dietary, yes.
Supposedly they were paid off to kind of point the finger at saturated fats and all the fats, which is where the
And
low
that,
fat
I
diet
think,
came from.
that's the worst mistake that we've had in the last couple of decades,
Mm,
when the people went nuts with the fat-free, low-fat. I believe that that's when the obesity epidemic happened and the diabetes epidemic happened, because people started concentrating on carbs,
yeah.
and the things that they were putting on the fat-free, on the low-fat, were all sugar or chemicals to substitute the taste or the consistency, right? And I feel that's when obesity started shooting, at least here in the United States, and the diabetes.
Yeah, and then with it, the periodontal disease and probably tooth decay as well, because sugars cause tooth decay. So it's all linked in. We could kind of pen this in this life to, diabetes and periodontal disease, but all these other things are going to feed into kind of how we need to approach things. It's kind of crazy and almost too much to bear.
Yeah, I feel like talking about this is like another reason why we should try to live a healthy lifestyle, right? And inform ourselves and get more knowledge on the things that we're eating, that the things that they're providing us, that we're consuming, is we can know and choose better.
Yeah, I completely agree there. And sorry, I'm just reading some of my notes. We were going to talk a little bit about the effect of maybe their effect on hormones as well, with diabetes. How does that tie into things?
So, well, definitely there's a decreased production of insulin, or your body doesn't respond as it would normally would. So there is a change in that hormone. Then we know other hormones that are affected, like the GLP-1, which is made in the small gut. In diabetics, it's found that they make less of it. So the GLP-1 increases the production of insulin in pancreas, and controls appetite. So we know that diabetics have less of that hormone, right? And that hormone also acts in the brain and the appetite center. So yes, definitely there's some hormonal shifts that we can see associated with diabetes. Not necessarily that they cause diabetes, but that they are associated. And same with obesity, we see insulin resistance, right? So that's another change in the hormonal.
I was going to ask, is that in any way linked to periodontal disease as well? Is there any effect of hormonal changes to the work that we might be doing as dentists?
So we think the periodontal disease, it has a strong link with insulin resistance or insulin sensitivity.
Yeah.
So or hyperinsulinemia, right, which are the main causes of diabetes.
Yeah, I think that's really interesting. And then obviously the kind of hormones affect saliva and things like that. And we know that in diabetes, there's a change in the type of bacteria that are present in the mouth, and these bacteria are more periodontogenic. I think that's the word.
Yeah, I mean, bacteria feeds on glucose, right? So the higher the glucose it is they're providing the perfect medium for the bacteria to grow. So that's why, and then the bacteria itself causes inflammation, and that causes rise in the sugar, right? So it's like a vicious cycle that is feeding into itself.
Yeah. What's interesting to me, and I think probably for the guys who don't know much about the work that you do, could you kind of walk us through the patient journey once they come and see you?
So once they come and see me, and talking specifically of diabetes, we go over their sugars, we go over their eating habits, we go over their exercise habits. I ask them to walk me through regular days, what they ate for breakfast, what they ate for lunch, what they ate for dinner, just so I get a sense of what do I need to work more on, right? And then we talk about medications. Usually I'm very pro, I wouldn't say against insulin, but if I can take a patient out of insulin, that would be my goal with that patient, except type 1 diabetics, right?
Yeah.
I'm talking about the type 2, if they come on insulin, my goal with that patient is to have them off insulin, because we have better medications that probably the GPs are not aware of it, or they don't feel comfortable using, and that's the reason they come to the specialist. So we have better medications than metformin, than insulin, that will help the patient many aspects in their life. So that will be my goal, is to kind of reduce their medication list and take them off of insulin if possible. And then we see them every 3 months. We do an A1C here in the office. And basically it's communication with the patient, right? Because sugar is not steady, or diabetes is not a constant. I mean, it's a very hard disease to have because there's so many factors day to day that can affect their sugar. That is not something set in stone, right? Stress, anxiety, not sleeping. I mean, many other things can affect their sugar, not just their diet.
Yeah. How big of an effect does stress, maybe within someone's life or work life, have upon the control of the diabetes? And how can we kind of manage that? Because if the diabetes gets really bad and the periodontal disease gets bad, we might end up losing teeth, and that's not a situation we want to be in because that's irreversible.
Yeah, so acute stress is okay. That's what protects us, right? That's our safety that helps us react. But chronic stress, we know there's chronic production of cortisol. That with time, this definitely can lead to obesity. And cortisol raises sugar on itself, right? So it's raising your sugar chronically, and then it's increasing your risk for obesity. So chronic stress is definitely a big contributor in your glucose control or your weight control. So we need to learn ways to manage our stress. Exercise is best, right? Everybody feels a little bit better and you release a lot of stress. I mean, sleeping well, meditation, yoga, things that can help. I mean, those things that you may think, oh no, I need a medication for it. No, I mean, certain things that you can do throughout your day can reduce your stress level.
Yeah. Is that a problem in the States? The kind of over-reliance on trying to medicate things before you make personal changes to the way you're living. Is that an issue that's commonly seen or not?
It's hard to say, to talk in general, but
Yeah.
me and for myself, if I see the patient has tried many things, if I see the patient has struggled for a long time and they're frustrated and they've lost hope, I don't wait anymore. I don't tell them, hey, eat better, exercise, I'll see you in 3 months.
Yeah.
No, I mean, we have medication. I believe in using the less medication possible, but I also believe that medication works for certain patients, right? I mean, it has its uses, and when it's used properly, medications are wonderful. So if I see a patient that has struggled, that has tried on its own, that has been to nutritionist, to dietitian, I don't wait. I just say, okay, do that, improve. That's always going to be part of treatment, even for diabetes, obesity, high blood pressure, and everything is going to be a part of health lifestyle. But let me help you, and let's use medications that can help you to get there, right?
So you kind of do kind of a dual-pronged attack. We're going to do some medication to kind of stabilize things, and on the other hand, we're going to hammer diet, exercise, sleep, stress management.
Especially because obesity as a chronic disease is such a new concept that it takes people to understand that it's not a lifestyle problem, right? So many people think that it's still a lifestyle problem and it's going to be solved by lifestyle changes. It's not. And that comes in medication. When you tell somebody there's medication that can help you with weight loss, I always tell the patient on the first visit, weight loss medication can be used chronically. It's not something that should be seen only as something temporary, because then we come into the maintenance part, right? And that's one of the hardest part. But people still think that once they lose the weight, the changes in their lifestyle may be everything they need to maintain the weight loss. But with obesity, we know it's a chronic disease, that it has genetic, environmental, other factors. It's not just a lifestyle. So we're in a time of change and a time of adjustment. So I think in the future, we doctors need to see obesity as a disease before the patients can actually accept it also as a disease, right? So it's going to be a matter of time. But I always tell them healthy lifestyle is always going to be important, and not just for the weight, cardiovascular, cholesterol, your joints, your muscles, aging. Having a healthy lifestyle is always going to be part of everything.
Yeah, I think I'm somewhere in the middle on that particular kind of topic of where kind of obesity lands as a disease. I think there's definitely factors which would bring you into higher risk categories of putting on weight and keeping the weight. But I think, and this is maybe anecdotal a little bit, but as time has gone on, for example, I was in the States recently, and the food in the States was totally alien to anything that I'd eaten before. It was much heavier, soaked in oils, soaked in carbs. And I wasn't surprised that people struggle in the States with weight, because that was a huge portion of food I got.
Yeah.
And it was poor quality. And yet this was the highest rated place in the entire city.
But see, that's the problem when we're talking about food industry, right?
Yeah.
And government, because ideally our food should not be so genetically modified. So all of those chemicals and all that ultra processing of food is making us obese, is giving us obesity in this country. So yes, ideally to solve the problem will be to solve the farming, the food industry, right? To not give us the processed, ultra processed food.
Yeah,
and that will solve the problem. But unfortunately, we're so deep into it right now that for many people, that's not going to be the solution. Hopefully for future generations, right? For the ones that are not born yet or the ones that are small, if those changes happen, then they wouldn't be affected. But for us, I mean, you're talking that you went to a good restaurant, right? That you would to be expected to have high quality food.
Yeah.
Imagine going to a fast food restaurant. I
didn't even go to a fast food restaurant. This was the thing, and that was the thing that was maybe the eye opener for me. And maybe I have a different viewpoint than my American viewers and your American viewers, because I'm from Europe and the UK, where whilst we do have an issue with some areas of our population having diabetes and obesity, nowhere near the levels that you guys are currently experiencing. And that was very kind of eye-opening for me.
Yeah, honestly, it's shaming. It's shameful, because I see many patients that are not from here, that they grew up in Europe or Latin America or other countries, and they come here and they gain 20-30 pounds. So it definitely is the quality of food. So it's a very big battle to win, right, with the food industry, because there's been found that they contribute to politicians. It's a $1 billion industry, right? But for me, my goal is to educate.
Yeah.
Even one by one, right? Educate my followers, educate my patients that there are ways that you can try to avoid going into that path. We just have to be smarter and question what is giving to us, and why is it giving to us are the other options, right?
I think that's
ways. The key. So to knowledge is power. And I always say the patients that know more do better.
Absolutely. And Doff saying genetic factors can cause just type 1 diabetes, or can it affect on type 2 as well?
Oh, there's many different types of diabetes. We normally hear type 1, type 2, but we have MODY, we have LADA, we have so many genetic form variances of diabetes that yes, definitely. There are a lot of genetic factors that can contribute to the type 2 diabetes, meaning not type 1, not type 1.
I think this is such an interesting topic, and I kind of want to touch on the obesity thing a little bit more, because it's linked in very kind of closely. And again, this is just by my personal experience of diabetes, of kind of obesity and periodontal disease and loss of teeth. There does seem to be a higher likelihood that there are periodontal issues when a patient comes in who is a bit more overweight. And that's possibly diabetes which is undetected potentially?
I think independent of diabetes, obesity can cause periodontal disease because of the inflammation. And there's a lot of studies that they just talk about obesity and periodontal disease because of the inflammation. So in those patients, we know that the inflammatory markers are elevated. So we know that their immune system is being occupied pretty much trying to combat that chronic inflammation, that we almost consider them at one point immunocompromised, right? So same things we're seeing with coronavirus now. And this is something new that we started seeing when it came to America, because not in Europe and Asia, there's not such an obesity population as there is here. So we were not hearing about it over there, but it comes here that obesity is an epidemic, then we start seeing that those patients are doing worse, right? And I mean, all the studies are being done, obviously, because it's still happening. But
yeah.
some of the studies that already come out, and they're telling you it's the inflammation, right? That's the basic concept, is inflammation that is keeping all your immune system occupied with that chronic inflammation from the obesity that is not letting you fight for new virus or new infections coming in, right?
Yeah, for sure. Perry, Princess, thank you for joining us, and thank you for sharing on my story. If anyone else shares any of the screenshots from today, then I'm happy to share those as well to give you guys a bit of a little boost.
And have a safe flight. She's boarding up.
Wear a mask.
I'm jealous. I can't wait to get into a plane.
We were talking a little bit about the maintenance phase after losing weight. Is one of the issues that people come up against kind of the idea of a diet versus a lifestyle change? Like a lot of people that I know, they'll go on a crazy diet, lose the weight that they want, and then go back to what they were doing before.
I completely disapprove those type of diets, and I don't recommend any diet to my patients because, one, they're non-maintainable, right? Second, I strongly believe that everything in excess it's going to be damaging. So if we overdo one thing, it's going to hurt us. And I think the maintenance part is the most hard to expect somebody to live with such a hard or strict diet, right? Like not eating or fasting, or I don't know, just eating fat or just eating this. So I don't recommend any of those things.
Is that the issue that comes up, that you see more commonly though, that people will try something and then once they've got to the goal, once that period is over, they go back to what they were doing?
Yes, but they get frustrated. They don't want that, right? I mean, they're not going into it knowing that in 6 months they're going to regain the weight. I mean, they are disappointed. I don't think anybody goes into it saying, okay, just for 3 months, it doesn't matter, after I'll regain it. But there is the lack of that communication, right? Between the physician, between the patient, and unfortunately, I think obesity and physicians stopped talking about obesity because the patients were being frustrated, the doctors were being frustrated that we wouldn't see results. So I feel like the conversation stopped happening, right? So, but I think I encourage people to first discuss with a practitioner what options do they have. Here in the United States, we have a specialty in obesity, which is something new. Now you can be specialized in obesity, which is so needed, right? We have thousands of cardiologists because of the heart problems, endocrinologists, but we were not treating the main base problem, which is the obesity, right? So I think now people should if their provider, if their primary care or their current doctor is not giving them accurate information or recommendations that can actually do, then look for an obesity specialist or an endocrinologist, because we do have the options now, right? We can do something about it.
Yeah. And what are the biggest changes that you kind of encourage people to make, or the things that you would ask people to do and look at within their kind of daily lives that you say, actually, this is going to make the biggest change for you?
To stop eating processed food or diet food, right?
Yeah.
To stop eating low carb, low sugar, fat free, sugar free, to eat them more wholesome and natural possible. I start with that because I think regardless of the weight, that's going to help them in the future with their health, and some physical activity, right? So, but we have to remind ourselves that 80% of weight loss is diet.
Yeah.
That itty-bitty 20% or maybe less is exercise. I recommend exercise for cardiovascular, for joints, for mood, right? For self-esteem. But that is not it for weight loss. We have to talk about diet. So switching the way they think about food and what they're gonna go and buy in the grocery store, for me is like the biggest thing that we can do initially, right?
Yeah. We've got Dr. Tini saying that if we consider the amount of obesity in the US, it's kind of mandatory to have that kind of a specialty. So that's really
Definitely.
good that we're now seeing that come through. And I was watching a podcast not so long ago with Dr. Rhonda Patrick. I don't know if you've heard of her. She does a couple of really interesting things, and she was talking about this is where I heard about the soft drinks issue. People drinking, going from a full sugar diet Coke to then a diet Coke, and the additive that was added between the two changed the gut flora so much that they were adding weight on at a much increased level to if they just drank the normal one. But again, it's that same thing you were saying about not having processed foods. Trying to make things from scratch makes a big difference.
Oh, definitely. Eating home, cooking themselves, having control of what goes in the food, how they cook, right? Less frying, more baking, more broiling. And definitely, I have patients that tell me, how about the Crystal Light or those drinks that you can put in water? I say, no, water. I mean, if occasionally you want to have a juice, just make it natural. But the majority of your drink should be water, right? So I don't give permission that, oh yeah, you can have some sugar-free, or no, just have the real stuff, but more gradually or less frequently, right? Versus the sugar-free ice cream every night. I tell them, have the real ice cream maybe once a week or every 2 weeks versus the crap, right?
Yeah, it's. I think some people call it the 80-20 thing, where they have 80% of the time they'll be very kind of good, and then they have a cheat meal every now and then, just with something that they liked or whatever it might be. But again, keeping that to reasonable foods.
Yeah. I'm also very pro in quality of life, right? So there's for me, it's not worth it having a patient be unhappy eating a salad 3 times a day, but with the sugar control, right? That's not also the point. I want the patient to still to enjoy life and to have a quality of life, because that's the whole purpose of it, right?
For sure.
Yeah.
Good afternoon, doctors. Accompanying you from Brazil. You are tops here, prosthetic Alex. Thank you, Alex, for the comment. Zachary, I'm not sure which comment we've missed.
He said, me too, I agree, doctor. I'm also an endocrinologist. So,
nice.
Hi, Zachary, you're an endocrinologist too. Nice to meet you.
Let's bounce right back to the periodontal disease. It was let me just get it back up because I had it on my iPad, actually, the actual study that I had. Guys, can you get some questions in? We want to see kind of your thoughts as well. But there was a reduction in TNF alpha after periodontal treatment by a dentist, which led to a HbA1c going from around 8 to 7.1% kind of reduction. And that's huge.
That is huge. In diabetes, we see interleukin-6 and tumor necrosis factor elevated, right? And again, they say that periodontal disease and diabetes, like, they feed each other. So it's not only one leading to the other. It's like both ways. And if one improves, the other one improves, right?
Yeah, I think it's so interlinked and so important to get on top of this, which is why I kind of asked you to come on and kind of give your expertise on the diabetes side of things, but also on the obesity side, because all three, I think, are very closely linked.
Yeah, and as we were talking a little bit, that it's you guys that may even think of diabetes before we even see the patient in the office, right? Because they may be going for you, they may not have any symptom of diabetes, or another very interesting thing of diabetes is it's not that they don't have symptoms, it's that they get used to it. Many times I have patients with glucose in the 300s, I'm fine, I don't feel anything. Once you improve their sugar, they say, wow, I was really not feeling fine. I mean, the body can get used to everything, right? So I'm very doubtful when they say we don't have any symptoms. I just feel they got used to it. But to my point is that they may go to you first because of their bleeding gums or anything than to us, right? Because they think all the other symptoms are normal.
Yeah, and that's the chronic elevated, hypoglycemia. It's chronically elevated, which leads to all these inflammatory markers increasing, and then we see the effect in the teeth, which is where we can possibly pick it up. What I was going to ask as well, with the obese patients, patients who are suffering from obesity, is it inflammation due to pressure on, joints, which is causing the chronic inflammation, or is it inflammation in the gut?
The fat tissue, the adipose tissue, it's actually an organ. We consider it a gland. So it's an active organ, the adipose tissue. So the adipose tissue can, with large amounts and chronic, it can produce inflammatory cytokines and all of that, right?
Got a question from Periodontal here. Thank you for that. Any advice for encouraging dental patients to take their glycemic control more seriously?
Oh my goodness! I mean, my father is a diabetic, and does not have any of his teeth. I mean, he lost all of his teeth. So it adds up, right? And it comes and gets you. So the problem with diabetes is that you think you can get by fixing certain things, but in 10, 20 years, it comes and bites you in the butt, right? Yeah. So I think we always have to just remind the patient what's going to happen if they don't improve their sugar, right? I think it's hard to tell them you're going to have this and this without them seeing them or seeing, in 20 years. But we always have to remind them what can happen. So patients, you can lose your teeth. I've seen so many patients with abscess. And then we also know that the mouth bacteria can affect the heart, right? So, it's a bacteria that can travel to the heart. So the mouth, it really needs to be taken care of, and having a good glucose is going to be part of it.
Yeah, it's really, they call it the gateway to body and health. And it really is. Whatever you're eating really does affect everything else that you do. Whatever you're drinking really does affect whatever you're doing. Yeah. And then don't even get started on smoking, because that's just, that's something that's really obvious, but we still struggle with as well. Thank you for the question, Periodontal. I think that was a really good one. She struggles with that with her patients, getting them to get on board with the cleaning.
Yeah, it's important to remind the patient. I always make a point of reminding them what quality of life you want to have when you are 60, when you're 70. We can get you there, but you may be in dialysis 3 times a week, and then you cannot travel anywhere, right? Or you may have your feet amputated. Or same here, then you're not going to have any teeth. You're going to have to be put in prosthesis. We have to make them think of the future, because we know it's going to happen. They don't. Sometimes patients don't. If they don't see it, they may not understand. But it's not that I'm fine in the moment. It's what quality of life you want to have when you're older.
Yeah, for sure. If you've got problems with your feet because of the chronic diabetic condition, that's going to impede
change your quality of life. Dialysis. Patients have to be 3 times a week in dialysis for the rest of their lives. They cannot travel. They cannot. It changes their life completely. That's not quality of life, right?
Thank you, Dr. Khushbu. He's saying that he practices in the Gulf, and they're quite ignorant of this condition. Just by looking into the mouth, you can make out the diabetic. That's from probably even the smell of ketones you can smell sometimes.
True. So, yeah, that's more of a type 1, but yeah.
Let's have a look what else I had on the agenda. I think we've covered most of the bits and pieces. Guys, if you have any more questions for Doc, then we've got about 10 minutes left of the live before Instagram kicks us off.
I would say for any endocrinology there, or patient or doctors that deal with diabetes, I think we always ask, have you seen your ophthalmologist for your yearly exam? Have you seen your nephrologist? Have you seen the podiatrist, right? I think we have to add dental. Have you seen your dentist? Have you had your dental clinic? Do you have any gum disease? Do you have any periodontal gum disease? Because we can try to prevent from them to losing their teeth. It's a big thing to lose their teeth, right?
I think it's almost for us as well to send them to somebody early if we're seeing signs of um, unexplained periodontal disease where there's no other issues, and you're thinking this could be a diabetic patient, this could be, you know, the issue. And the reason that I kind of this is flagged up to me is because I saw within dental school a patient that I saw for 3 years regularly, doing all the cleaning perfectly, but things would not improve.
Mm.
And on the last visit, she said, "Oh, I've been to my doctor. It turns out I'm diabetic and it's been really poorly controlled."
Oh, yeah.
So all that 3 years worth of work completely ruined because we didn't know she was diabetic.
Oh, that sucks. Yeah.
And that's kind of one of the reasons I want to bring this up. And we're going to have a clinical nutritionist on tomorrow who's going to talk the same thing. She deals with a lot of diabetic patients as well. So that's kind of why I'm going quite hard on it.
Somebody says, for uncontrolled diabetics in need of an emergent invasive dental procedure, will you recommend prophylactic antibiotics? I think that's probably for you. I think you guys always give antibiotics, right?
Not in the UK. I think it's unnecessary. I think there's not much evidence around that. Once you've removed the source of an infection, which is the tooth, I don't see there being any issue with.
I think Dr. Vando's referring for uncontrolled diabetics.
Uncontrolled.
I think for those patients, in my point of view, the best thing we can do for them prophylactically is to control their sugar.
Mm.
Because they'll have less risk of infection, they'll have better healing. So I think more important than give them antibiotics is going to be to controlling their sugar, right? To have
controlling the sugar and maybe some local measures within the surgery, making sure we have got perfect hemostasis before they leave, maybe even suturing and putting it back in and suturing so that we know that's going to heal as fast as it can, and there's going to be less chance for bacterial ingress. And good oral hygiene control as well. That's going to be important. What's the oral routine recommendation for a diabetic patient? Is there anything that you would recommend to help with diabetics?
I mean, again, the most important thing is to control the sugar, right? To control the sugar. But other to that, I mean, to floss regularly, to brush their teeth regularly. So just to have good oral hygiene, but I don't think anything special. The only thing I would add for that is excellent glucose control or improve their glucose control.
Yeah. Yeah, I think I tell my periodontal disease patients to be using things like interdental brushes and maybe even things like a water flosser, because I think there's a good effect in removing any potential pathogenic bacteria and plaque. I think that's probably the best thing to do for those patients.
Yes.
And regular cleans. Any more questions? These are great questions, guys.
Yes, thank you.
Let's have a little look. Period seems to have gone. What are the other things that you do in your office, kind of moving away from the whole topic today, just so we know a bit more about what an endocrinologist does?
So I do thyroid disease, so every hormonal problem, hypogonadism, menopause, polycystic ovarian syndrome, Cushing's disease. I do my own ultrasounds, which today I was preparing. I do my thyroid ultrasounds. I do biopsies of thyroid nodules. I need to do be biopsed. So general endocrinology, and then added to that obesity. That's pretty much what I do.
Yeah, and where do you kind of see your career going in the future? Do you think you'll be in the same sort of space, or do you think you'll specialize further within endocrinology?
I don't know. You know, when I did my fellowship in endocrinology, there was no obesity medicine. So I think if new things are coming, and they apply to what I want to do, then definitely I'll keep specializing. Definitely, I think there's much need of obesity treatment, right?
Which do you kind of enjoy the most, you reckon? Sorry.
I think diabetes and definitely obesity when I help a patient lose weight, or when they've tried and they're frustrated, and then you give them something that actually works for them and it starts working and they're very happy. So definitely that.
Yeah, I can imagine that's probably something you could probably do quite regularly within the area that you're working. you know, with the kind of crisis there is within diabetes and obesity in the States.
Yeah.
How much of an issue do you think? One of the other things that I noticed was everything is so far away, you can't really walk anywhere. You have to drive.
Yeah, so I mean that's why I like New York, because here you
Yeah.
don't need a car. You can walk everywhere. You take the subway, you take the bus, you take public transportation, or you can walk pretty much the whole island of Manhattan, right?
Mm.
So I think here in New York is a little bit different, but definitely outside is it's harder because they depend on cars, right? I mean, when I used to work in other places that were not here, I always tell my patient try to park
Further
farther
spot.
away, so you're gonna walk a little bit more, take the stairs. So things that they can do that are that can be done in their place that they live, right?
Mm. Yeah, because one of the things that I noticed was there was things called zoning in the States when I was there, and you couldn't have shops or like a supermarket or a grocery store in the area where people lived. You had to drive to the area where the shops were. So there was no kind of choice to actually I'm just going to walk 5 minutes down the road to the shop and pick something up. It was
Yeah,
really
I mean, it's a shame, right? It's also the type of lifestyle that we have here. Is
mm,
that's what we refer to lifestyle, right? I mean, diet
yeah.
and lifestyle is the lifestyle that we have. It's very sedentary, and then we work many hours, and then we don't have time for that. So there's many things that need to be changed, and we need to be re-educated. And I guess that's one of, when you ask me what's the things that give me more satisfaction, is to teaching people, right? The things
Yeah.
that we know that not everybody knows that can help them. So just teaching people how to eat, how to make better choices, healthy choices. I think that really does makes me feel like, okay, I'm doing my job.
Yeah, I think that's kind of the same thing. Like, I don't like doing the periodontal disease treatment. I think um, it's a shame in a way because it's not the most interesting. It's just cleaning around the tooth, but the actual giving of the advice, I really enjoy that part because I can list things off and the patient can say, oh, actually, I didn't know about that. Oh, I'll try that. And then if they come back in a couple of weeks and you can see a difference already, uh, that's a big kind of like, oh, I've made a difference there. Um,
Yeah,
and
yeah,
I think that's the best part.
that's why it's so important to still talk to the patients, right? I mean,
Mm,
it's pretty much you come in, they do it, they don't talk, hi, how are you? But it's like the communication is like every patient is a different person, it's a whole world, right? And to help them, we kind of have to be like detectives. We have to play detectives and find things, right? And yeah,
yeah, I think that's kind of the secret between a lot of healthcare is kind of pinpointing the issue because everybody, while they may have a similar disease, they may be eating something slightly different, which, you know, sometimes we're asking, do you have a sugary diet? And they all say no, of course. So you need to find out exactly, because they think sugar is, I'm adding sugar,
yeah,
literally adding
sure,
sugar.
sure, sure.
So you have to really dive into their habits and
Yeah, yeah,
pick out exactly what's the big kind of culprit.
yeah.
Guys, any more questions for the doc? We've only got about 3 or 4 minutes left. Have you got any kind of quick fire tips that we can tell everybody that's going to help with the management of diabetic patients?
So I think first of all is changing the way they eat, right? Cutting back on the processed food, on the ultra processed food. If they know that they have some family history of diabetes, then it's good always to bring that up with the practitioner, just so they always keep an eye on it. Or if they're already pre-diabetic, to try to work to avoid developing the diabetes, right? And
Yeah.
I think just having your yearly physician, your yearly dentist appointment can help for us to find things before the patient may start feeling it, right?
Yeah, kind of that screening appointment. We do it for all cancer, we can do it for diabetes now as well, if we know what we're looking for, as well as doing all the other dental things that we're used to.
Yeah, for sure.
I think we've run out of questions from the guys.
Yeah.
But thank you for coming on. Hopefully we've not taken up too much time. I hope you've enjoyed
No,
it.
no, 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 no. But it was a
Hopefully
great talk.
yeah, hopefully we'll maybe catch up at some point in the future, maybe next time within, and give some further tips to the guys and kind of re-raise awareness for the
Yeah,
whole link between diabetes and periodontal disease, and maybe anything else that we can come up with.
definitely. Yeah, for sure.
Uh, Thank you to everyone who's watching as well. I
Thank you.
think we're on number 60 since lockdown of live podcasts. So if you want to kind of support what we're doing here, have a little look in the link in my bio, and there's a couple of things that you can do there, which will help us out. Thank you, Doc, for coming on, and
Thank
see you guys
you.
later.
Bye.